Hey, welcome to the Go To Physio ankle joint series. Now in this series we're going to cover some key assessments, some key rehab techniques and tips to make sure that you don't flare up a patient, you don't skip steps, and you can really differentiate yourself as that go-to therapist. So with the ankle joint, we need to understand from a whole body approach that as that foot hits the floor, again, excuse my lovely ankle joint here, we want the forces to be distributed each and every direction, okay? And what you're going to see with a lot of patients that have had all ankle injuries is that when the motor adaptations kick in and there's stress or there's higher level loading activities, is we'll very subtly start to avoid loading certain parts of tissue. So the big toe and the little toe in particular are going to be two areas that we may be interested in, that when an athlete or a patient is doing an exercise, are they avoiding loading certain parts of those tissues? So when we load the big toe, obviously the peroneals are going to have to react. When we load the little toe, we're going to get that inversion torque, which is going to get the tib post to fire. Now the big thing that we need to understand about the ankle joint is that the ability to have good intent through the midfoot and forefoot is critical to help the tissues above it, which is the hamstring, the glute, and the quad, to all do their work as well. Okay, so if we lose intent through that ankle joint, then we can have consequences further up the chain. Okay, so without further ado, let's get into the content. And in today's episode, let's set the scene, and then in the coming episodes, we'll show you how to assess, how to treat, and how to take that patient through a step-by-step process. So welcome to the ankle joint month, and the ankle joint is one of the most underappreciated injuries in sport, and especially when you get into rugby and Gaelic and football. When we get an ankle sprain, we almost are a little bit too dismissive of them, in my opinion. Okay, so what I tend to find then is that some old ankle injuries could be potentially causing the athlete to maybe compensate, okay, or the nervous system to develop other strategies which may short-term protect that ankle, but long-term then develop maybe new movement habits, okay? And we can see from research, done years ago, that even up to a year later, that the function of the hip can sometimes be altered with, chronic ankle instability cases, okay? So we have to be careful with the ankle that we do a great job of not only restoring range of movement and having good intent through the foot and all the muscles, but that we give the body back as many options as we can again, so that we don't lose any movement variability. So the big thing with the ankle, which are subjective assessment, is the direction of force or the mechanism of injury. So if you have an ankle injury and it's your classic, they've rolled the ankle, then we obviously want to be careful that there's no fracture or anything like that, okay? And if they've got pinpoint tenderness, you can use your Ottawa rules, and especially any pinpoint tenderness on the fifth, the base of the fifth metatarsal, and also the distal tip of the fib, then we may be suspicious that there may be some kind of chip there of bone, etc. I've seen that a lot in my time over the last few years, so just be aware of that. It may not necessarily alter the management drastically, but it's still good to be aware of that, okay? Now, if the athlete reports that they have an ankle injury maybe medially, okay, or they feel the pain at the front of the ankle, and they've done the injury where their foot got stuck on the floor and it twisted, for instance, or as they were twisting, somebody came in and maybe chopped their knee, for want of a better word, then we would have to suspect that there could be potentially syndesmosis injury. Now, syndesmosis injury is one of the most misdiagnosed injuries out there, and it's in my opinion, and it's very important that we can recognize this, because the management of a syndesmosis injury needs to be correct from the minute it happens, basically. And from my own clinical experience, if you mismanage these injuries early doors when they actually happen, then they tend to really hang around, okay, and that they can be quite hard to get the athlete back. Whereas if you manage these injuries correctly from the time that they happen acutely, we can compress the ankle joint, we can unload the tissues or put the athlete in a boot if possible, then these athletes, from my own experience, tend to do very, very well. Okay, so recognizing the syndesmosis injury is very, very important, and that's one of the big things I want to be aware of in this month, in the ankle joint month. Okay, so the mechanism, whether they roll inwards or whether they twisted and pivoted, then we need to consider syndesmosis as well. Okay, so with that said, let's get started. Let's have a look at the syndesmosis assessment. Let's have a look at the normal ankle assessment and get comfortable actually identifying a syndesmosis, because that's the one really in university that if we were showing it, I probably didn't pay enough attention. But as I said, the consequences of not picking up this, can be pretty big for the athlete in terms of return to play and helping that athlete get back to where they want to get back to. Okay, I hope you found that useful, and what we're going to do now in the coming episodes is we're going to start to set the scene and show you how to get clarity with an assessment, how to make sense of your patient's symptoms, and then get going with a rock solid foundation of a treatment plan, rather than building a treatment plan that's ultimately built on sand. As always, if you want more information, head over to thegotofysio.com. I've got plenty of tips and resources there for you, my exact protocols that I've used in professional sport over the last 12 years. So I'll see you next time when we start to put together the objective assessment.